I want to talk a little bit about translational and therapeutic implications. So, from a translational perspective, how might modulation of inflammatory pathways enhance therapeutic efficacy? For example, in patients receiving, hypomethylating agents or targeted therapies.
So, developing this to a more translational project and moving it to the clinic is obviously particularly challenging. In AML, we know that we haven't made amazing progress on the survival of these patients for many, many years, and improving azacitidine venetoclax outcomes has not been particularly easy. But I would say there are a couple of ways. One is targeting these inflammatory pathways. It appears to be promising, at least in preclinical models. Obviously, clinical trials need to be done. We know that IRAK1 and IRAK4 inhibitors, for example, appear to be quite effective when combined with venetoclax in preclinical models, or when we have developed those drugs that target both IRAK1 and 4 and FLT3. So one way is to target these pathways. The second way would be to target pathways that molecules that activate downstream signaling, such as JAK-STAT pathway. So targeting JAK2 with ruxolitinib has not been particularly effective, but we haven't seen so far any even preclinical studies looking at STAT inhibitors in that setting. So that I think would be very interesting too. The last approach is what we have been doing in my lab for some time. We have tried to develop antibody drug conjugates, where we use as antibodies that target a number of downstream genes that are regulated by interferon gamma signaling, including CCRL2 and ICAM1, particularly in TP53 mutated MDS AML, where we don't have available antibody drug conjugates. So just targeting the molecules that we know that are overexpressed in these leukemias.
Mhm. And even outside of the drugs or combinations that you're thinking about in your lab, are there any candidates or combinations that are showing promise in preclinical models?
If you're referring to specifically inflammatory
Yes.
signaling, I don't know any others other than the IRAK inhibitors. I mean, IL-1B inhibition in earlier stages, we have tested for clonal hematopoiesis, but not in advanced myeloid neoplasms. Obviously, ruxolitinib is a treatment that is, in my opinion, non-specific, and it's more an anti-inflammatory agent in myelofibrosis and polycythemia vera. Now, these are the main, I think, combinations that have moved a little more than just preclinical models.
Hmm. And then, are there any specific inflammatory biomarkers such as CRP, cytokine profiles, or phosphosignature markers that may predict which patients are at a greater risk of treatment failure?
I think this is a hard question because, AML, particularly, and MDS are in general very inflammatory diseases. So it would require a very high number of patients, big cohorts to study that. Definitely, I don't think CRP or ESR, like non-specific markers, would not be, I think, something that I would look into. But I think, for example, IL-8 has already been identified as a possible marker of bad outcomes for patients with MDS or AML, but not in the context of treatment. So that would be a very interesting thing to look into.
And just kind of thinking forward on that, in that line of thinking, how might these biomarkers be incorporated into clinical decision making or even trial design going forward? Any thoughts?
I think I would start with clinical trials that are ongoing, including those inhibitors like IRAK1, IRAK4, and other inhibitors of nuclear factor kappa B. There, I think they are studying some of those cytokines. The other source of data for this is myelofibrosis, because ruxolitinib is a very good agent to target inflammation, and I know that they are looking at cytokines there. So I would start there, look at specific responses and correlate with cytokines, and then move it to perhaps MDS and AML.